Okay, we're about ready to have the all-star team from Jefferson here. Dr. Sato will be leading it off. We've discussed, we have, I think it's a number of speakers in a row, each are doing relatively short talks, and what we'll do is then have a question and answer session afterwards. So we'll just run through one talk after another. If you could hold your questions, write them down, and then we'll answer them all in the end. Dr. Sato.
Good morning. First of all, I have to appreciate Ocular Melanoma Foundation to give us this opportunity. It's very important to us to know each other and to give our idea to you, and then understand each other, and then I'm pretty sure you can just give information that you get to the other people. That increase the awareness of this disease. Also, we can work together to find the cure for this disease. I start seeing a light in the tunnel, so I want to share some information today. And then this is teamwork. That is our strength here. And luckily, each of my colleagues are able to come out here to give you their idea, their information to be given to you. So, but since we have a limited time in discussion, kind of a presentation, so therefore I will just ask individual people, doctor to finish their lecture quick, and then after that we can spend more time in Q&A. So if you have any question or something that you don't understand, including my English, just write it down what Sato said. So we're going to clarify that later, okay? So I have to admit that when I came here 20 years ago, I'm almost kind of blind about this disease. You know, I don't know what I should do, but actually my boss tell me what I should do this. And then 10 years ago, I start seeing some light, and then I'm still very nearsighted. So whenever a patient comes and then with a big tumor, we have to just take care of that. So, and then luckily we have a colleague here. We developed a new program, liver-directed program. I think we triple the survival, especially for the patients who have liver tumor. And then now I start seeing a little bit better vision, but I also have to admit I'm getting an aged eye. So, so let me, I think I want to just repeat the same thing to make you understand what individual lecturer are talking about, because some of them are very professional in our terminology. Okay. Let me just I will spend the first 5 minutes to explain my concept of eye melanoma development and metastasis. So I might have to change the figure or concept after 5 years, but this is, as of today, my belief that what is going on in eye melanoma. Okay, so this always fantastic picture can be given by Dr. Harber's work and then Dr. Shields' work, and I think this is a beautiful picture. As you know, you can see. The first thing happened is GNAQ, GNA11 mutation. This is an abnormality or mutation in the receptor, which getting a signal to the cell. Then, if it is mutated, your signal can be transmitted inside the cell. And then this mutation is not activating mutation. This is a deactivating portion of the mutation. Therefore, if signal comes in, keep coming in, you cannot stop it. So that's a dilemma, because if it is activating mutation, in other words, mutation keeps sending a signal, you can block it. You can shut down the signal, and then that's it, you have a cure. Problem is, if you have a problem in deactivating process, only way is just reinstall that mechanism or block the downstream. So therefore, this is a similar situation to the situation called the NRAS mutation, okay? Anyway, we don't know why this GNAQ, GNAB mutation is going to start it. But this is like a major driving force to make the melanocyte to be actively a growing cell. But by having this only, you have a blue nevi. Tumor is not going to go any place. Then eventually, tumor has a second abnormality, which is chromosome 3 loss or 6p gain. And then here, BAP1 mutation. BAP1 is a tumor suppressor gene. Again, this is a loss of tumor suppressor gene, so therefore, the treatment is installing a suppressor gene. That is impossible. So therefore, again, everybody working in the area close to that. Same thing for these two genes. And BAP1 mutation basically make the tumor cell aggressive, but at the same time, I would say tumor cell become a tumor melanoma stem cell. Okay. And then BAP1, HDAC inhibitor, so-called valproic acid and others, is going to manipulate the abnormality of the BAP1-related mechanism, not directly attacking on this. So therefore, this is not direct attack on BAP1, but manipulating the area of abnormality. So it is not direct, still weak. All right. This is also Dr. Bill Herbert's slide. This is class 1. This is class 2. You see the morphological difference. This is more attached cell. This is more sphere. And these cells are kind of have a characteristic of the stem cell. In other words, de-differentiation. Melanocyte is a pigmented cell attached on a dish. And then if that's changed to the class 2, BAP1 mutation can make the tumor cell really more very primitive, in other words, stem cell-like shape. And then you see the KIT overexpression in the class 2. So KIT is one of the receptor which we have been looking into, and we have been attacking on that. But one of the mutation, overexpression of KIT is present in the class 2 cells. So understanding is this tumor became really more cancer stem cell-like change, which means very difficult to kill by the chemotherapy, very resistant to the radiation treatment. That's the kind of thing that happens if a tumor becomes class 2. Then another thing that we think, once a tumor cell become more stem cell type change, they start expressing many molecules which make the tumor cell move to the area. Because we have a, a stem cell can make an organ. So they have to move into some place and then differentiate, right? So tumor cell express several very important receptors which make the tumor cell move to somewhere. So that include the, escape. Motility is a movement, and escape from some area to get into that. And at the same time, this stem cell-like signal is going to help the tumor cell survive, and then resistant to chemotherapy and others. One of the molecules that we are looking into is a so-called MET. This is like a New York Met. You should not be confused with MEC. MEC and the MET is different, okay? So MET is a molecule which expresses on the surface of the tumor cell, also in the cells. And that brings the tumor cell is very mobile, move to somewhere. Then next slide is important. Tumor cells circulating around the body, and then some tumor cells come into the liver, and then in the sinusoid. And this is from artery, the tumor cell there. Then this tumor cell express MET receptor, also IGF-1 receptor. That is a little bit more stemness. Then liver cell produce IGF-1, insulin-like growth factor 1. And liver parenchymal cell, like sinusoidal cell, produce so-called hepatocyte growth factor. So now you reach to the liver, and then you have tons of nutrients. So a tumor cell like it. So that's the one theory why these tumor cells tend to grow faster in the liver. Okay, there might be many other receptors which stem cells like to use to grow and move to somewhere. Okay, so one of these mechanisms you could think how to block it. So that's maybe the clue for the new treatment. But the reality is, as somebody say, whenever you have a big tumor class 2, tumor is in the liver.
So therefore, all kind of c-Met mechanism moving to somewhere is not going to work well. For example, c-Met inhibitor is going to be tried, but c-Met inhibitor may not be useful because tumor is already there. And then getting a signal from the not only hepatocyte growth factor or IGF, you know. So this is a headache. So it's going to be shown by Dr. Kauho this afternoon, so it should be very brief. But this is an area of the G protein. All right, G protein sends a signal spontaneously because there is no like a deactivating mechanism. And there's a couple of researchers, investigators working on how to block it. And then now he's going to talk about MEK inhibitor. Okay. And then we're going to have a PKC, protein kinase C clinical trial. So they are going to block these both. And then now c-Met here, IGF-1 here, they can skip this blockade by going to this different direction and coming back to the end. So it's kind of very difficult race. But we are able to see the target very well. We are kind of finding out the mechanism why this is happening. Now, several sequence is going to be targetable. So, for example, c-Met can be targetable, MEK inhibitor can be targetable, PKC can be targetable. So this is kind of this afternoon's key discussion. But this slide are probably available on the internet eventually. So this is the kind of way you understand how tumor cell develop, what the class 1 mean, BAP1 mean, how tumor cell can move to the liver, then what's happening in the liver, and then what the target is. This is a kind of summary of all kinds of scientific discussion that you're going to talk today, this afternoon. Okay. Now, go back to the strategy for improvement of survival. As Carol say, most important thing is detection of the tumor in the early stage, treat very quickly and efficiently. And then, for the some tumor, which is already out, as you know, class 2 BAP1 mutation. So then what we should do? We have some good news and then dilemma. Anyway, the strategy for the improvement, first of all, risk assessment to find out who is going to have a problem, who is not going to have a problem. So that's very important because I cannot give a treatment for the patient who has no risk. Right? It's kind of very tricky. Second thing is to try to prevent. There have been nothing available for 20 years. All of a sudden, we have at least 3 approaches, actually 4 approaches available soon. And then early detection. This is going to be discussed by Dr. Carin and others. Risk assessment, probably I can skip it. Carol mentioned that, and then Peter mentioned that. And this is class 1, class 2. I'm sorry. This is especially monosomy 3 and then 8q amplification is quite different from others. I feel that especially metastasis, we tend to see the 8q amplification. I think 8q amplification is a very important factor to drive the tumor cell move to somewhere and then grow. Especially c-MYC, MYC, MYC. c-MYC is there. c-MYC is an oncogene to promote the progression of cycling of the cell cycle of tumor. So that might be important. Okay. So this is class 1, class 2. You already know about that. Then we use like a risk assessment, and then based on risk, we are going to change the approach. And then Carol may have a different opinion, but for the sake of discussion, I just make it 3. Low risk, disomy 3, disomy 6, disomy 8. Castle Bioscience class 1A. Thickness is less than 3 millimeter. Diameter is kind of debatable. But this type of patient are less than 10% risk of having systemic recurrence. So on the other hand, if patient tumor has monosomy 3, 8q amplification, Castle Bioscience class 2, and diameter is large, and then thickness is very thick. This is unfortunately at least 50%. Some data says 70%, 80%. And then there's an intermediate group. It's a very miscellaneous of many others. Okay. Then what we are doing for the low-risk patients, we just see the patient every 6 months or 1 year depending on patient's decision. And liver imaging, we're going to talk about this. Dr. O'Kane talk about that, but we tend to choose MRI. He's going to explain the reason. And blood test is usually useless. However, that is required for the kidney function test, so we are going to add some tumor marker there. And chest X-ray annually. And the high risk, we know that the tumor come back a little bit earlier, quicker. The 2 to 3 years is a major peak for the high risk melanoma. And low risk tumor can come back 5 to 10 years, sometimes. We have to be careful. But high risk, for the first 2 years, we are doing very intensive testing. And then we use MRI on a routine basis. And then after 2 years, move to 6 months. And then after 5 years, annually. And then chest metastasis in the chest is 10% of whole population melanoma patient with metastasis. So the argument is CT scan of chest or chest X-ray. But for this high-risk group, we tend to use CT scan of chest every 6 months for 2 years, and then annually thereafter, 3 years. And then now adjuvant treatment, we are going to talk about that. Intermediate risk, and then we are seeing a patient every 6 months. The adjuvant treatment is additional cancer treatment given after the primary treatment to lower the risk that the cancer will come back or prevent the growth. So there are many types of immunotherapy, chemotherapy, radiation therapy, and then many others. Then this is a reality. There is no approved medicine for stage 4 disease, so therefore there is no medicine for the protection or prevention. So that's a reality. Then the second thing is very challenging because even though you have a 70% risk of death, you have a 30% of not dying from that. So and then you have to tell the patient and discuss patient, how you want to do that. Patient may say, I should be on the 30%. I don't want to do that. We have to be very careful in discussing about that. So, and then most of medicine which has been used for the stage 4 metastasis patients. So therefore, there's no long-term follow-up. So what's the long-term side effect? Because if patient live 10 years, medicine may be good for the prevention, but if patient die from different cause, that's a major issue. So we have to be very careful. So therefore, as of today, standard care or general suggestion is watch for observation. And then the adjuvant treatment should be done based on the clinical trial or mutual understanding of experimental nature of the treatment. There are 3 approaches, and I would say 4 is coming. One is sunitinib, a Sutent. The other is histone deacetylase inhibitor, here in this case valproic acid, and the anti-CTLA antibody. This is immunotherapy, enhance the immune system to induce autoimmunity. Okay, and then number 4 is a c-Met inhibitor. c-Met inhibitor is controversial to my knowledge, but there's a group that c-Met inhibitor will be tried for the prevention. The argument is tumor may be already there, so why you have to prevent migration of the tumor cell? That we have to discuss. Sorry for the busy slide, but we are going to open the randomized prospective clinical trial in which a patient is going to be either taking Sutent or Depacam, valproic acid. But we only treat the patient who has high risk, which means either monosomy 3 ATQ amplification or class 2. So this type of patient, is going to be enrolled and then randomized into, either 1 or 2 arms, and then treatment is 6 months. And then we're going to follow every 3 months for 2 years, and then we just follow every 6 months. And then many research, like a basic research testing is going to be done. Who is going to get the benefit, who is not going to get. So therefore, there are a bunch of testing on that. But luckily, we have medicine free of charge from Pfizer. So, and the major, struggle is over. However, we still need some funding to do some, basic research. And then once we got the funding, I'm going to expand this to the different institution. most likely first institution is going to be University of Miami. And then hopefully we can extend this to the West Coast. Okay. Then why sunitinib? We already have the pilot study, which has 65% disease stabilization in metastatic uveal melanoma, and most of the uveal melanoma in metastasis has c-KIT expression. We saw that the suppression of c-KIT by the Sutent might be useful, but we were not sure about that. And how important c-KIT is, we don't know. And also the c-KIT Sutent is anti-angiogenic agent. Cancer cells need new vessels. So therefore, if you block the new vessels, cancer cell cannot grow. And then this is additional immunological factor. This medicine suppresses the some suppressive cell which cancer cell attract from the bone marrow. So cancer cell doesn't have any blood. Cancer cell doesn't have any soldier to fight against the immune system, and then cancer cell has attack on the growth signal. So that's a rationale. And then on the other hand, valproic acid, VPA, that is comes from the in vitro experiment and the animal experiment. This is Dr. Harber's result. If you give valproic acid to the mouse which has eye melanoma tumor, and valproic acid is suppressed, not totally get rid of that, but suppress the growth. And that means probably tumor cell is less aggressive. And also valproic acid can potentially stimulate natural killer cell killing of cancer. So there are a couple of factors so that's the basis of that. So everybody is interested, but there's no data, so therefore we are going to get the data prospectively to tell the patient and doctor one of these medicines can be used or should not be used. And then, as you know, there is the ipilimumab study at MD Anderson Cancer Center. This is a medicine, I can go this, to enhance immune reaction. If T cell is activated, T cell can express the molecule called the CTLA4 to adjust the intensity of the stimulation. So eventually, after activation, T cell is going to be calmed down. And some T cell has this molecule to suppress the other T cell. And then if you have a blockade, so-called the Yerboy, you can stop the suppression. So therefore, if T cell is activated or recognizing cancer, they can attack on the tumor. So that's a concept. But this mechanism is not only for cancer, but also normal cell. So therefore, a bunch of autoimmune reactions such as gastroenteritis, colitis, skin rash, loss of function of thyroid, loss of function of pituitary gland, myositis, neuropathy, 10 pages of side effect. However, the concept is interesting, and if it is a clinical trial basis, I think it should be okay. This study, they are using probably 10 milligram, this higher dose, okay? And you can contact MD Anderson Cancer Center. Nowadays, we have a so-called clinicaltrial.gov. You can punch in this number, you should get the information. The Adjuvant Sutent VPA trial is not registered yet, so that hopefully within 1 month, you can get more information. Okay. And, again, we have to stop. And this, I don't want to talk about I'm not the only person who working here. We have a team. Teamwork is important. And I want to tell the patient, my role is just talking. talking. And then after that, Dr. Eschelman and Gonsalves can take care of the patient. That's the end, okay? Finally, this is my team. And the big group. And actually, Dr. Fremont yesterday told you, but we are chosen at a team science award, from the Jefferson. And also, I have to appreciate all kind support from the patient and family to keep our basic research, clinical research moving forward. Okay, thank you.